before we go to that, let me accept to what Alice has said. I think it's true. We have a point, the public have a point, and it is a point that I want to make an appeal to all health institutions, be they government, be they private institutions. Good corporate governance dictates that whoever is serving you needs to be known, identified. And I just want to say that when I go back to the board, I think we will have to do a circular letter. Probably I'll discuss with the Director of Medical Services so that the circular comes from the Ministry of Health to either to both public and private facilities, that healthcare givers must be identified, not even named, by designation. Because you get in and they are consultants, and you cannot differentiate between a consultant and a medical officer. You cannot differentiate between a medical officer and an intern, and you can't differentiate between a clinical officer and a nurse. And I think some of the cadres take advantage of this. And because everybody would like to be called Mheshimiwa, and the minute you are called doctor and you know for sure you are a patient attendant, then you feel your ego is elevated. And I think based on that, people have kind of sat on that, and I think, Alice, I appreciate that. We'll take it up. Now, you're talking of retraining. Let me tell you that 5 years ago, in tandem with the best practices world over, because Kenya medical practitioners and this board subscribes to the Association of Medical Councils of Africa, which brings all the medical councils of Africa. In fact, currently, Professor Mago is the president of the boards of Africa. We are also members of IAMRA. IAMRA is the International Association of Regulatory Authorities. It was noted that practitioners all over the world needed to keep up with the changing medical science. And as a result, it was resolved that doctors must be involved in continuous professional development. We have made that as a requirement, as a regulation, and we have sat together with the professional associations and developed these guidelines where a practitioner must attain at least 50 points in a calendar year before the renewal of the practice license. And we go around and take part in these CMEs, they call them CMEs, continuing medical education. Hospitals invite us for presentations in their institutions, and we also get in experts coming to give keynote speeches in various forums so that practitioners keep on improving their skills and knowledge. So it's a regulation now, it's a requirement, and we already have about 100 practitioners whose retention in the license in the register last year was deferred because they are not complied to that regulation. If you defer them, then what does that mean? You defer, then they must within 1 month or 2 months show proof that they have acquired the relevant skills. We've even put that CPD in our website. It's in soft. There are tokens. Doctors who are, because the challenge was that you organize for seminars and about people in the remote areas. How do they access? With your mobile phone, you can easily access to CMEs on online, which are programs and certifications can be issued online. So doctors, nurses, and clinical officers, I do know they are taking that keenly, and the reviews of the guidelines has been undertaken. I think the clinical officers, the lab board, launched the reviewed guidelines in December. The medical board has reviewed theirs because, as I said, 4 years ago is a long time. So we have completed review, and we are soon going to launch the new guidelines for doctors.
On the issue of training, I would also like to put this forward. A lot of times the doctors, the care providers are trained on the clinical aspects of treating the disease, such that when I come into a hospital, I immediately become a disease chart. Is a cancer case, is a kidney case. They are not trained on handling the emotional being, the person, treating the whole person. And that is one thing I have found as I was doing this work. And that is why a lot of times you find a doctor, a nurse, or whoever is attending to you is in a hurry to just treat the disease and not even listen you out. I think this is something that Daniel and the medical fraternity need to be looking into, because before you see me as a patient, can you see the human being who is suffering? There's a model worldwide now called patient-centered care. Can we go back to bring the patient as the center of everything that we are doing? Before we see the patient, can I see Mwakazi, can I see Mutegi, a human being who is suffering? Can this be incorporated into the medical training, other than the clinical aspect only. Somebody said sometimes even hearing this person out is better than will heal the person faster than just pushing that drug into their mouth or the jab. We have seen that to happen when somebody knows that somebody is empathizing with me, somebody cares about me, my family is being taken care of, because a lot of times families are also treated so badly. You ask questions, and the relationship between the care provider and the patient is one of hostility when it should be one of mutual trust. So I'm thinking that incorporating the science of healing the whole person other than the clinical issues alone should also be incorporated in the medical.
Yes, I think I talked about training and I talked of continuous professional development. The issue of training doctors in this country, the medical board is mandated to approve the training core curricula. Last year we reviewed the minimum criteria for admission into medical schools, because we realized that quite a number of Kenyans who train outside go there when they have not met the minimum admission criteria within the country. That is one. Number two, we have decided to review the basic requirements to be included in the core curriculum for Bachelor of Medicine and Bachelor of Surgery and Bachelor of Dentistry, so that institutions that come up to train doctors are guided, they stand guided. And I think some of the issues Alice has alluded to are addressed in that core curricula, is newly launched and we have disseminated it. Only that the right to information, is key regardless of your status. So patients go to health practitioners and you talk to them and they finish looking at you and they make their decision, and they have not explained to you what they are doing, and they have not even told you the implications of the decisions that they have done.
Communication is key. Maybe sometimes we are fighting over nothing, but because the doctor feels I am so down there, I won't understand. In fact, one doctor, when I was going through all this, asked, "When daktari unataka kumtibu?" Simply because I was asking questions. I need to know, my patient is in a coma, can I know what is being
Alice,
treated?
I think, thank you. If I can finish, one, even the doctors themselves are on their toes. One, with ICT, patients are browsing their conditions, their symptoms, their expectations, prescriptions, even before they go to the doctor's consultation. They already know that the drug of choice, first line is this, alternative is this, and these are the symptoms. And when they are asking the practitioners, they are just asking to confirm, because they already know. So
how many patients?
Let me finish. Now, the practitioners, there is this joke, and I think it came from your organization, Alice, where they said the only thing that you can read from the doctor's handwriting is the bill, the amount of money. This came from her. Because she complained to me. She said that they are not helping them. But practitioners now need to let them write clearly. Let the patients understand. Let them explain. Even when patients go for certain procedures, they need to be told this is what you expect. But the patients themselves also have a challenge. They decide to go to traditional healers, and next time I think I will demand that you get them here, we talk this out, because we're having a challenge. People go to traditional healers, they are there from January to December, and when the patient's condition has completely deteriorated, they move to Kenyatta. So now when you move in here, they don't disclose that this is what has been, this is what we've been taking. Others even bring in the traditional medicine together in the hospital. So you are given conventional and traditional on the other side. So I think this is also another issue. We need to come out here.
Briefly, you could mention this one, this case of misdiagnosis. Does that fall under somebody's patient's right? Should I go and complain?
Yeah, I think the issue of misdiagnosis, we have about 72 cases of misdiagnosis. But I wouldn't say they are done by doctors, because we get cases from all levels, including the small clinics and so on. When the practitioner has missed that diagnosis, you have a right to complain. When the practitioner has given you wrong diagnosis or wrong procedure, because there are patients. It was reported, the case in Tanzania, where somebody was to be amputated the left, and they ended up amputating the right, and that was a case that I had to attend in Tanzania and get the feel of it to ensure that it doesn't happen here. So it happens all over the world. So you need to explain to your patients. The doctors and the clinicians need to take a moment, think, reflect, discuss issues, and confirm. And even when they are giving you a prescription, let them tell you this is what is expected, because some drugs react, and some drug reactions are anticipated. In some of the cases they bring with the board, we take them through and say, this is it. Now, there's something I mentioned about the PCC, which I had introduced. We have also, we have looked at the patient, because in the past we would just look at the practitioner. What is it that we do? We order the practitioner to go for training. We order the practitioner to be suspended from practice for a certain period of time. Now we are looking at the patient. What is it that the board is doing to the patient? We have amended our law to give power for arbitration, so that a practitioner whom we find in our own evaluation is the one liable, can sit with the patient, and they reach an agreement. Now, people are ignoring that. We have given that directive, and people have decided to ignore that directive. The amended regulation in December 2013 is giving the board now power to constitute that arbitration committee if people so wish. But the minute we have given you power to arbitrate and you refuse, then the practitioner goes to court and sues. Let me finish this, because it's key. The public will ask, what do we get out of the complaints from the board? And that's what we are telling them. The minute we have said that we found Dr. A culpable, and then we are telling them to sit with you and talk, that is enough. You can go to court, and using that judgment, put the board's proceedings on the table. And this is expert opinion. Then that gives your case an added advantage. Not a guarantee, but added advantage.
I'm afraid I will have to stop there. I'm a man under authority as well. We'll stop there. Thank you so much indeed for your comments. Thank you so much for being part of the Power Breakfast Show team. We totally appreciate. You have rights and responsibilities as a patient. My name is Johnson Mokazi.
And I'm
and of course our guests here. Let's meet tomorrow as God wills. All the best.